So my name is Mona Drage. I'm from Norway. Since we've already had our workshop, we can't use this as an advertisement for you guys to come and join our advocacy workshop. Some people were lucky and could do that. So we've decided to run you through the main things that we had in our advocacy workshop yesterday. So this will be like advocacy speed dating. There will be no time for introductions. We're just going on and on until we've exhausted all the topics we had. And then we are lucky enough to have Professor Njeka, or how do I pronounce it correctly? Njeka, the NTP manager for South Africa, to close us off. So we're very excited about that. So I just want to call Bruce Matawari and Dickens to come and join me for our joint presentation. So, we want to cover the topic of data-driven advocacy. Why is it worth investing in pulmonary rehabilitation for tuberculosis survivors? So yesterday we decided we had some advocacy recommendations on our part. It's that we need pulmonary rehabilitation for everyone who needs it, at all levels, district, community, tertiary level. We need to partner with civil society and TB survivors for implementation and training. We need to collect data to show impact and benefits. And we need to integrate PR and post-TB care into the national TB strategy. So we will go into each recommendation in detail.
Hello, everyone. My name is Dickens Bwana. I'm from Tanzania. And I work with the TB survivors organization called Mkuta. I'm here to also accept that pulmonary rehabilitation sites should be for everyone who needs it. So in Tanzania, we piloted this program in the non-mining site at the mining site. And the program was designed to check how is it possible to do pulmonary rehabilitations at primary healthcare level, meaning the health center, tertiary, the hospitals, and also dispensary level. So we had tried our best to do it along those lines. And we established at least one pulmonary rehabilitation site in the mining and 5 in the city setting to see how program can work. And the program was fully managed by community health volunteers. So I think it's so important to say that there was a consensus on the screening modality. So this was the accepted PTLD diagnostic algorithm that suggested what could be the feasible role of TB survivors or community health volunteers. So in this case, we assigned community health volunteers actually to do the screening of all those who have previously treated for pulmonary TB. So they went out with a list looking for the patients with signs and symptoms and bring them back to the facility. But because of time, I just want to emphasize that there was an integration of other comorbidities. So those who are screened, not eligible for PTLD, but actually had other conditions and other illness, were systematically linked to other departments for support. And that shows already NCD was taken care of within our program. So you can see how the program was arranged by excluding those who had TB and not, and you can follow that, and I'm available for additional explanation. So the interesting part was that all these TB survivors, all the community volunteers, were able to screen at least 625 people in the mining site. And you see how the results were presented, that at least 88% of these were presumptive, and confirmed PTLD clients were 75%. And we went down to 121 who were eligible and recruited in the PR site, and it was interesting how they were supported. But it's also important to note that at least 70% we were not able to link them to the PR site for some reasons based on occupation and the setting of the program. There was a distance between where they were doing the mining and where the PR site was set. For the non-mining site, we did this to 1,379 people, but at least 57% of these were confirmed PhD, and 96 actually managed to attend our PRA sites, which I can understand, and you understand that in this urban setting, that could be easy for them to access the PRA site. But before I move to the next slide, I must say that we had 24% of recurrent TB in the mining side. So actually the aim was to look for PTLD, but actually we found that we can find other additional cases within this group. So for us, if you check the 24% and the 10% in the non-mining site, we are confident and we can suggest that PTLD actions can also help us to have additional cases in these settings. To sum up, I also want to call upon you to understand that if you map partners, they can do a great job. Check how the community volunteers were able to partner with the health system and the TB survivors to implement the simple and standardized pulmonary rehabilitation and ensure that the trainings are available. So in summary, you can see how this was provided. It was managed by community volunteers, and where the PRA sites were actually implemented was at the community parks, identified in collaboration with the PTLD patients and the community volunteers themselves. And these are simple open spaces close to the facility that were identified. It was bi-weekly. They do the assessment using simple tools, but PRA services were scheduled together with the patients. How many times do they want to come and what type of exercise they do. So basically, I want to echo that there was a consensus on the package to provide. So breathing exercise, education, counseling, nutritional support, small packages accompanied with that, but also strengthen endurance exercise were provided. Okay, so I'm suggesting that we can put pulmonary rehabilitation in action by simple training and supporting community volunteers with right training and tools and that kind of support. Thank you very much. Yes. Bruce.
All right. Thank you, ladies and gentlemen. As Muna said, this is like a speed date, so I'll try to be as quick. So as Dickens was explaining, in Malawi as well, we also did a pulmonary rehabilitation program at facility and community levels. So we also used TB survivors to implement the program to facilitate and community health workers with amazing results. And I think these are important in terms of advocacy, because as you see in our presentation, it's data-driven advocacy. So even data at community level being implemented by patient organizations such as Paradiso or Nkuta can really, really make an impact. So one of the recommendations that we have is collect data and to show impact and benefits of interventions happening. So in Malawi, we assessed about 1,721 TB survivors, of which 70% of those had health problems. Of the 70%, 60% had lung complications. And many of them also expressed that these health problems affect them in their daily life, in their economic life, and in their social life. So this data was very compelling and also helped us to build a case for advocacy. Continuing with the findings that we used to advocate for post-TB, especially post-TB lung disease in the country, the data that we collected of the 1,721 also showed that unemployment rates rose by 60% post-TB comparatively to pre-TB. And then people surviving on less than $1, also that rose post-TB comparatively to pre-TB. So having these findings, they revealed that the human cost of ignoring post-TB is really, really a huge problem, and they gave us a powerful advocacy tool for us to be able to advocate. It also showed that a healthy population is a productive society. So when we're doing our advocacy, that's also the angle we used. Apart from collecting data and evidence, we also had to figure out what could be possible solutions when we meet people in leadership and decision-making positions. So because of the highest lung complication that we found in the cohort, we designed a community-based 12-week lung rehabilitation program on how we could manage patients with PTLD. We had a cohort of 467 participants in 9 sites. After just 12 weeks, we saw the reported measurable improvements in their exercise capacity, respiratory health, and also mental health and well-being. We followed 110 of the 467 a year after the rehabilitation program, just to see if the impacts were sustained. Because of time on this speed date, I will just take you through two indicators that, parameters that we measured a year after. So in terms of cough and exertion, you see that at baseline, it was 62%, at endline it was 10%. A year after, it's 7% having this. In terms of the mean in meters of the 6-minute walk test, you see that at baseline it was at 397, at endline it was 475, but at year after the lung rehabilitation program, when we followed them up, it was about 480 meters. So having all this data, these solutions, and TB survivor testimonies, as we've seen here, we had a very powerful case to hold. And because of that, we were able to get post-TB, both in Malawi and Tanzania, in the national TB strategic plans. Both countries have developed national TB PTLD operational guidelines and standard operating procedures. That was also supported by the Global Fund Strategic Initiative. And TB registers in both countries have post-TB indicators. Capacity strengthening and for community volunteers and healthcare workers and post-TB knowledge is mostly available in most communities now and the health system. And in Malawi, with the National TB Program, we have rolled out the lung rehabilitation program in 13 facilities outside the 9 that we worked on. And post-TB management has also been added in the curriculum of the University of Livingstonia in the country. And I just wanted to add that in terms of the advocacy, we had been engaging governments and other stakeholders that were key from the start of the project until the end, where we had accumulated all the data, and also had different mediums in terms of the information, packaging it into documentaries, having live testimonies from TB survivors, and presenting the data. So that really helped a lot. Thank you so much. Unfortunately, I'm not the last person on the speed dial. On the speed date.
Thank you very much, Bruce, for that. So maybe I want to add a few points on that, Bruce. For Tanzania, it's advocacy group you know very well. So after the well-done job by the community volunteers, we made a lot of noise for the NTP in Tanzania to ensure that at least they include the PTLD interventions and particularly pulmonary rehabilitation into Global Fund Grant Cycle 7. But also, we called upon inclusion of all these interventions that was done into the PTLD Practical Approach Manual with support from NURAD, but also Global Fund Strategic Initiative. Yes, a lot was done, but we encountered several challenges. As it was said yesterday, a lot of interventions and issues are already mentioned in different documents. And we want to say that there is still a difference between what is claimed in the policies and guideline in the actual implementation. So we are calling upon partners to fast track this and ensure that the services are made available. But also the budget constraints. We also piloted what could be the ideal budget lines for the pulmonary rehabilitations. And we say that issues like nutritional support, transport stipends, does not go well when you talk with the government, but we say food is medicine. It has to be costed in the PRA site. Lastly, there is a difference there is a low awareness and capacity among healthcare workers and other partners in the non-project sites, which should be taken on board as we plan to roll out the pulmonary rehabilitation. Let me hand over to Muna to take you through towards the end of the presentation. Thank you very much.
Yeah, you can stand.
Now I leave the stage.
Yeah, so we gathered some of sort of our conclusions or our tips. I think it's very important that we don't overlook the psychosocial and behavioral benefits and reduction of social isolation and stigma during this group pulmonary rehabilitation work in the community. There's a quote here from one of the participants. Even others who are not part of the program, we play together sometimes at the ground, and sometimes we skip rope with the kids at home. These are just my friends. Some have issues with their blood pressure, others have diabetes, and many who have come to appreciate the need for exercises. So I think that was one of the most interesting findings, that how exercise became so easily adapted in communities where exercise was not common. And we also saw that among the 110, they had been continuing their exercise that they had learned during the pulmonary rehabilitation. So we need to include education, counseling, and behavior change for the sustained health effects, and including the mental resilience. Like Dickens said, food is medicine. We can't say that too often. And data-driven advocacy is not cheap, but it's definitely worth it. So, our conclusions. Yes, for the PR, adaptations have to be made, even within countries or contexts, but it is possible. Pulmonary rehabilitation isn't a luxury. It's a low-cost, high-return investment in public health, economic productivity, and health systems resilience, and not to mention the effect on the individuals. So we are thinking, can we go local, which is scalable globally while feasible to adapt locally to specific settings or countries? And I say thank you and invite the husband of Oluwatosin to continue the speed dating.
Thank you for that apt introduction. So my name is Essen Nkerewem. I'm a clinical research fellow based at the MRC unit, the Gambia. I'm presenting on behalf of my wife, who is Oluwatosin Nkerewem. She's a social scientist and research coordinator. We are both based in the same institution, and unfortunately, she was unable to be here. I will use the next few minutes to convince you to ensure that children and adolescents are included in your thought process as you're planning and conducting post-TB research. And I'll be talking about how we centered children and adolescents in the work we were doing in the Gambia. We did this by ensuring that their voices were heard. So we conducted a childhood TB sequel study, which was a quantitative study that spanned from the time of TB treatment completion up to 1 year afterwards. And for this qualitative study, which was embedded within the large quantitative study, we conducted facilitator-guided group discussions and in-depth interviews. And we focused on listening to the children and the adolescents and hearing their perception and definition of the disease experience. We used some innovative tools, which included art-based research methods, included use of collage making, body mapping, and drawings. And in these methods, the children were able, and adolescents were able to express how the disease felt to them and how they defined it, considering that many of the terms we use in our quantitative studies are kind of heavy science words and not necessarily available in the local context. So we let them express these feelings on collages and body maps and drawings. And we also encourage them to use storytelling and games and role-playing. And one of the things we found, my slides are without numbers, but if you want to know more about the results, the poster is there in poster number 46, so I would encourage you to visit after now. But we found that the groupness of the children encouraged them to share experiences and to talk about some of these shared disease experiences. And we ensured that these exercises were age appropriate, designed to promote safety and open sharing amongst them. And the picture there is one of those sessions where the children were engaged in cutting out newspaper clippings to express collages of their disease experience and their post-TB experience. And why is it important to ensure that we capture the lived experiences of children and adolescents in our research and not just collect the numbers? As you've heard in the pediatric session yesterday, and you will hear some more in the pediatric session today at 2 p.m., which I'm inviting you all to, children and adolescents face unique health challenges which are different than adults. Children are not small adults. We've continued to emphasize that. And it's important that we not only listen to them, but we listen to them in the way that allows them to converse and to talk with us. They would always require a trusted space. For those of us who work in pediatrics, you know that it's difficult to see an adolescent with the parents or caregiver in the same consulting room. So you want that trusted and safe space that allows them to express themselves. These images are some of the images of the adolescents who had made collages of their disease experience and were now talking with them and telling the researchers what it meant to them. And finally, it's important that we consider use of participatory and culturally sensitive methods that evoke interactions amongst them. In a setting which is very conservative, with adolescents not having a lot of voice, it was important that we ensure that the space was safe and allowed them to express themselves. And it's important that we move also from these stories to systems. Are these methods scalable? Definitely, yes. It's important that we consider listening deeply, adapting creatively to suit our context, and respond in a way that the voices of the adolescents are heard. And it's important that we consider advocacy for children and adolescents as a participatory event and not just that we are collecting data from the children. We must design with, not just for children and adolescents. Thank you.
Hi, everyone. My name is Kirsten Pravodas. I'm an infectious disease fellow at Indiana University, and I'm going to be sharing some of our work, qualitative work around health, well-being, and care needs after TB treatment in East Africa. So in the Tuberculosis Sentinel Research Network of IDEA, which is a global prospective cohort of people with pulmonary TB aged 15 years and older, with and without HIV. They're enrolled at treatment initiation and in East Africa, followed for 2 years after completing TB treatment. In East Africa sites in Eldoret, Kenya, and Mbarara, Uganda, we conducted in-depth interviews with people with TB and with multidisciplinary healthcare workers who provide TB care. And we conducted a reflexive thematic analysis of these interviews. So we had 80 interviews that we analyzed. 24 were with healthcare workers, and 60 were with individuals treated for TB, of whom 50 had completed TB treatment. And I'm just going to share some of our themes in the interest of time, but for a more complete look, you can also come see my poster this evening. So people experienced trajectories of illness and recovery across physical, economic, social, and mental domains of well-being, with improvement from the height of illness, but ongoing challenges for many. Some of these challenges included continued symptoms, including respiratory issues, fatigue, functional impairment, difficulty recovering economic livelihood, continued isolation, and mental health challenges. Despite challenges, narratives evinced resilience. So there was physical illness could exacerbate economic vulnerability, which in turn worsened physical health and was a barrier to healthcare access. Experiences were marked by stigma, isolation, and mental health burdens, which continued into the post-treatment period. And there was a lack of access to post-TB care and a need for person-centered care. So now I'll just share some themes related to post-TB care needs. So in the physical domain, lung health evaluation and rehabilitation were a concern, as well as detection of TB recurrence. As this participant said, I request that you now start treating my lungs. It's the only problem. On the economic side, people spoke of financial support and nutritional support. Support financially, it can help a lot. That is the beginning of everything if you're financially stable. On the social side, people spoke of the need for human connection and encouragement. As this participant said, I mean, to come back to normal, say just that love. You know, love is one of the supports so that you come and fit as a normal human being. And there was strong advocating for mental health support and counseling. As this healthcare worker said, after this person has suffered this TB, they still need to be encouraged that life is good, they can still live well, they can still become what they want to be. So in conclusion, we found that the post-TB period is marked by ongoing challenges for many, including persistent symptoms, economic vulnerability, isolation and stigma, and mental health challenges. And many of these experiences are neglected in the current care paradigm, and so there's a need for accessible, person-centered post-TB care models. Thanks.
Hey everybody, good morning. I'm Samita Kumar. I'm the Senior Associate Director for Global Mental Health at the US-based INGO, the Carter Center, and a doctoral student at Emory looking at post-TB mental health. I think at this point in the conference, I have less convincing to do about why mental health is so important in this agenda, but I'm just going to drive home a few points looking ahead. So in our session yesterday, we talked about the high global burden of mental illness, with 1 in 8 people living with a mental disorder. And we talked about how, with this overlapping with the TB burden of disease, that we really have a huge segment of the population that's affected by psychosocial impairment and mental illness. And that when we look at TB, particularly with the studies focusing on TB from the period of treatment diagnosis to treatment completion, we see a lot of co-prevalence of mental illness and TB and bidirectional relationships between the two. But like both diseases, our health systems are really not capable of taking care of this issue alone or together. People experience both of these issues together, but we treat them in silos. So they go to different providers and to different systems of care for both mental illness and TB. And coupled with that, we have a huge shortage of human resources, service disruptions, and then the care-seeking barriers that are often seen and have been talked about with stigma, fear, isolation, and then individual knowledge and beliefs. We talked in our session about how, despite this limited evidence on mental health after TB treatment completion, we're still seeing some emerging data come out from studies, and we're hoping to see a lot more of this in our next symposium on where this intersection really falls. So we've seen for mental health, especially in relation to some of the other key markers or symptoms of post-TB experience, like lung function and exercise capacity, that there is a significant association with mental illness, and particularly mood disorders like anxiety and depression. We also have seen a lot of external and self-stigma during the process of recovery, and as you've heard from the amazing storytelling in the past 2 days about how it's really isolating in the post-treatment period to be able to be in one's household or in one's community or be able to seek care for that. And then lastly, we talked about the absence of peer support and community support in being able to recover and what that limited touch point looks like from the health system as well. So as we move forward, some of our continued research gaps is to really take a deeper look from the quantitative and qualitative side of what is the magnitude and nature of mental illness in the months and years after TB treatment completion. How does mental illness function over time, and how does it affect disability and quality of life as people recover and try and find their new norm? And then, as we've talked about with social protection and with other safety nets, what is the role of specific interventions in psychological, financial, or social behaviors to help aid recovery and mitigate some of those impacts? And I think all of this, as we'll hear in our last presentation, would hopefully give us ideas on reasonable ways to think about integrated service delivery, which is a very nice idea to think about, but hard to put in practice. And so with that, I will conclude just to champion in the advocacy of our advocacy agenda. It's really important that we think about these multiple dimensions of the post-TB period and how many people they're likely to affect moving forward. And so we can critically evaluate how sufficient our current system is to be able to meet that need, generate data that's obviously useful for integrated service delivery, but also helps us use more specific examples in our advocacy efforts globally and at the country level to say this is what we should be doing and this is what works and this is what doesn't work. And so I would say in terms of mental health specifically, that is also another sector where we can think about advocacy for TB and not just looking at TB outlets, but use this comorbidity as an opportunity to get into other spaces where we can share the same knowledge and broaden the network of champions and advocates in this space. Thank you.
Hi everyone, so my name is Pumeza Tisile and I'm an ex-TB survivor, and I'll be co-presenting quickly with Ingrid. So most of us at TB Prof, we like to combine our stories with science, And I've also learned from this conference that the end of the TB treatment is actually not the end, because some of us suffered a lot when we were on TB treatment. So that is just a summary of my story, so I'll just give a brief overview. So I got late diagnosed, and that led to me having to drink medication that was not working for me, toxic medication that was not working for me, and that led to me having XDR at the end. So I started on normal or drug-sensitive TB. The drugs didn't work. They told me I had MDR, and at the time I had to get the injection, the kanamycin injection, and unfortunately the side effect of the injection is permanent deafness. And I was told that they were sorry, and I was not informed that I should expect this from this drug that I was taking. I was not informed of the fact that I was taking a drug that would potentially cause hearing loss. And I was not given a choice of either I want to be deaf or either I want to be dead or either I want to continue these toxic medications. There was no choice at all. But then after that, I was told I had pre-XDR TB. And it was just a long, long journey. And while I was on pre-XDR TB treatment, again, toxic medication that I didn't need. And it led, again, to many things like collapsed lung, for one, and another was a broken rib, because I had to undergo surgery where they broke my rib, and they said mistake happened. And I was told, again, they are sorry that this happened. But eventually, I was accurately diagnosed after 2 years with XDR. But then on that life journey, it means I got hearing loss through the injection that I didn't need, and I got lung failure because of whatever reason that was going on at the time. Again, I was not informed. I was treated as if I was just an object, because that's how some of the physicians were doing it. But luckily enough for me, after 3 years and 8 months, I was cured of XDR TB. And I was blogging about my story while I was on treatment, and that's where I came across MSF called Doctors Without Borders, and I got exposure to actually share my story. And I said at the beginning, we've learned the hard way that the end of TB treatment is actually not the end, because there are things that are beyond TB treatment as we take them. And I was cured and was able to go back to university, and I've been doing this, trying to influence change and working closely, for instance, with Dr. Nopet Jeka, where we try to push as much as possible for the guidelines to be released, where we try to push as much as possible for the community to know what's going on when it comes to TB. So so I didn't have to do this work like I'm doing now, because I was cured, I was okay, I was able to go back to university. Oh, by the way, I got my hearing back through cochlear implants, very expensive. So I forgot that part. Yeah, very expensive. So not everyone, again, is able to access R500,000, $40,000. But because I was blogging at the end, as I said, so it was easier for me to do the fundraising, and I was able to get them both at once, fitted at once. So back here. So at TB Proof, we try to pursue health equity by advocating for person-centered, high-quality TB prevention and care for everyone affected by TB. And at this instance, I used my voice, I used other people's voice, whereby we did this petition. We've learned that there is a drug that would actually potentially replace the injection that caused hearing loss, and the drug was out of reach, or the drug was not really approved at the time. And we just wanted a patient to have a choice on the drugs that they are taking. That was one. And not long ago, we've actually won a petition through Johnson & Johnson, where Johnson & Johnson was pushing this drug now that could replace the injection to be more expensive, meaning it never made sense to us as a TB survivor by making the drugs and not having them accessible to people who actually want the drugs. So we won that. It was a big thing, and I was mentioned in Time 100 Next, 200 most influential people in the world. So it was a big thing. And not to brag, but I'm friends with John Green. And there's a book, I haven't read the book. I edited the book with him, and I'm actually featured on the book. That's, what is it again? You have the book. Everything is tuberculosis is. So it's just, we've learned at TB Proof that I'm working closely with the National Department of Health. They are not enemies, they are very nice people. He's here. And they actually do listen. So we did also try to destigmatize. We tried to destigmatize all forms of TB stigma, because yes, we are cured of TB, but it's not easy to stand here and talk about the fact that we actually survived TB. So there are videos that we've done. One of them that is unmasked, and I think it won international awards, whereby we featured medical doctors who actually had TB, and also they were sharing their story of having TB. So thank you for listening, but now over to Ingrid to share briefly about her story.
Thank you, Pumeza. And I'm very proud that Prof. Njeka and Pumeza are here, because both of them played such a big role to change our guidelines in 2018 to drop the injectables ahead of the WHO. So I am bragging about South Africa quickly. So my name is Ingrid. I'm an XTR TB survivor. I'm living with peripheral neuropathy. I was in hospital 75 days, over a month in ICU, got liver failure from the TB drugs, and I'm proud to be part of TB Proof. What we've been discussing in our working group is that we've got lots of working groups, lots of priorities. So how do we take this forward? And using frameworks like Kaufman and Beer's framework, if we want to see policy change, there's different audiences and there's different actions that we have to take collaboratively if we want to achieve a goal for policy uptake to see post-TB being implemented at community level. So therefore, I think going back, just to think about consensus building, some of the things that we've spoken about is the awareness raising, demand creation. We want champions to ask for post-TB care once they've finished treatment. And then operational research, what package of care is needed. Luckily, there are studies underway to help us advocate for what is it that we're actually asking for? What is the package of care? Because it's not just lung rehab, it's not just mental health. Advocating for resource mobilization, for better research and development and implementation, and getting guidelines up, seeing it implemented. So in many developing countries, we've got excellent policies, but there's a delay in implementation. So how can we help to get implementation guidelines, get health workers trained, just move the process a bit quicker? And we are honored to have Prof. Njeka to help us talk about how national TB programs and how the TB program managers can help to get post-TB on the health agenda and on the TB agenda as well at the moment. Learning from other programs who got post-TB indicators in the NSPs, etc. I think those were great examples. Thank you, Prof.
Asked to discuss whether this is a political priority in South Africa, but I will answer also looking at the global perspective, a little bit of it. I'm Norbert Njeka. I'm Chief Director, TB Control and Management, South Africa TB Program. I must confess, whenever I do policies, I think about my past as a physician. I've had some experiences that I will never forget, like this young girl I treated for TB. It was really quite painful. I had a small child, same age at that stage. I had another young man who would not be well, and after treatment, it felt so bad. I went through these experiences, treating XDR in the ward as their physician, and you count bodies. This one dies, the other one. I think those are experiences that I always have in mind whenever I write policies. Whenever I discuss about policies, I think about those experiences. And of course, post-TB disease is a reality. I can't be preaching to the choir. I think you've been saying that. I will skip this slide. But just to share something with you, we do have a lot of patients with TB in South Africa. Our incidence is very high, 427 per 107 population. We're talking 270,000 per year. We find probably 80% of that. But at some point when we introduce the shorter regimens in South Africa, we're wondering as to whether these regimens are performing better than the older ones. And you will see on these slides, what we looked here, we're comparing the patients who got injectable versus the other that were on oral. But you'll see that at the end of treatment, we said that the success rate was 74%. We had cured 407 patients. We looked at the same record, went to OMA first. 2 years down the line, you'll see 45 patients have died from that 507 that were declared cured. And it was very, it was just evidence that the end of treatment is not the end of treatment. They still die. And this is precisely my life. I've seen that before, and I always felt that we should have been doing this a long time ago. I tried getting colleagues in Rwanda, in Botswana, through the Green Light Committee, GLC missions, to say, but you saying yourselves that you treat them, then they die later. Nobody was documenting. Nobody wanted to give us funds to do any research by then. So what did we do then in South Africa? We decided that despite the limited evidence recognition, but because there's really global advocacy around it, we started to measure. We decided that after 6 months for treatment, we should be looking at what's happening. Call the patient. You'll see, these are some of our records, how they look like. We do 6 months and 12 months. We're supposed to be doing. But this never been published. We look at it internally to see whether there's really appetite. It is a priority to look at that. In 2021, we cured 20907 patients. Only 433 came back 6 months down the line. And you'll see at 12 months, 153 came back. So so post-test, we recognize this as a priority, but it's not been prioritized in terms of implementation, because I think that's really where the difference is. We have a lot of issues. You bring in bedaquiline, you start to see resistance. You lose staff who can update your records. Now you want to update, but there is some evidence there that we're looking at it. But this is really a very small number. You can't have any big conclusion on this except to say that we have excellent healthcare workers in this country who are doing their best, who are checking the patients, and we really need to encourage them. We need advocacy, we need communication, mass communication to say this can be done. Some people are doing. In future, I'll tell you the details so that civil society is aware which provinces, which districts are doing this, because that's the only way you can get everyone to start doing this. So this, I thought maybe I should share with you. And really, I would like to conclude by saying that this is real, it's a problem, it's preventable, it is manageable. And we need to include this in all our guidelines and redefine what is a success. For many years, we've been saying 90%, 80% success rate, but it's not true. We need to be rethinking how do we decide who's successfully treated and how we should be doing our data. So I really want to call to action. There's a need for WHO to endorse these guidelines, and there's a need for international expert groups to continue working on this, give us a good definition that is understandable by all, including civil society, and your national societies, NTPs need to develop own guidelines on how we're going to be doing this, so that this is included as well in the surveillance and national TB plan. On that note, I thank you so much for listening. Thank you.
Thank you so much. I'm Camilla Romanowski. I'm an epidemiologist. I'm a postdoctoral fellow. Sometimes I meta-analyze data at exactly the right time. I have the distinct pleasure of co-chairing the EPI working group with Dr. Sophie Huddert, who unfortunately was unable to make it, and Dr. Carlos Almadia, who is somewhere in the stage. You should come sit up there. So before we begin the session today, I would just like a quick moment to take a quick moment to thank everyone in the epidemiology working group who's listed on the slide for the time and effort that they put into putting together the presentation today. So for today's presentation, we've decided to break it up into 3 sections. For the first section, we're going to set the groundwork. We're going to talk about what is epidemiology and why do we need it. The second section, we're going to explore descriptive, predictive, and causal post-TB questions. And then for the third section, we're going to demonstrate how we can leverage data for better post-TB insights. So to start us off with the first section, we have Kamban Harrison, who is a senior researcher at the Health Economics and Epidemiology Research Unit in Johannesburg, and he's an early stage health economics PhD candidate at the University of Cape Town.
Thanks, Camilla. Morning, everyone. So my name is Kamban Harrison. And on behalf of the Epidemiology Working Group, I'll be kicking off the session on epidemiology and the power of data. This is my first symposium, and I was told that it generally draws a very diverse crowd of healthcare providers, researchers, policymakers, advocates, as well as TB survivors. And so we thought it might be a good way to start the session with a brief definition of epidemiology. And in essence, it is the study of the distribution and determinants of health states and aims to answer 5 main questions. So who or which groups of people, specific ages, sexes, socioeconomic backgrounds, and genetic makeups get what, which health state, condition, illness, and or disease, where, generally referring to geographical location, when, in time, or at which stages of life. We know that some conditions are more prevalent amongst infants and newborns, while others are more prevalent in children, and more chronic-related conditions more prevalent in adults. And the million-dollar question, why? So which factors are associated or correlated with, predict, or even cause the outcome of interest with some level of certainty or confidence? And a basic question we are attempting to answer at the symposium is, following successful TB treatment, which types of patients suffer longer-term effects of TB? And this could be both clinical in nature, like diminished lung capacity, social, or even socioeconomic, like reduced labor force participation. In which particular high-burden regions do these patients exist? And again, why? And in attempting to answer these questions, epidemiology allows us to challenge long-held assumptions and by systematically examining data rather than relying on anecdote and tradition. And many of us will remember that up until the early 1960s, smoking, for example, was common practice and actually endorsed by many clinicians around the world. And following some large epi studies in the 50s and early 60s, the links between smoking and certain types of cancers have been clarified. And this is not a judgment on the act of smoking, that's a personal decision, but more a comment on how epi and data can shift the collective consciousness of society, which we also aim to do in the post-TB space. So for decades, TB research focused entirely on cure rates, and I think we focused on the correct problem for the time. However, with more effective treatment models, shorter and better tolerated regimens, our focus should expand not just on the binary outcome of cure, but on the context and quality of that cure. And to this effect, we have many colleagues in the space that's challenged these assumptions. I think Taylor and colleagues showed that up to 60% of patients have abnormal spirometry following TB treatment completion. Camilla and colleagues demonstrated that healthcare utilization is sustained following TB treatment completion, with patients having up to, I think it was 12 outpatient visits related to respiratory conditions. And Menji as well demonstrated that a year after completing TB treatment, about 19% of patients had declines in FEV1. I think Dr. Allwood presented something similar yesterday, and it seems like we are moving in the right direction. This is just a simple PubMed search with a single keyword, post-tuberculosis, and we see that over the last 6 years or so, there's quite an increase in post-TB related research. So apart from challenging assumptions, EPI allows us to drive solutions. And once we have identified gaps and patterns through epidemiology, we can use this knowledge to drive solutions. Data-driven insights help us refine screening strategies, identify high-risk groups, and guide future programs and interventions. And if we find certain populations experience higher burdens of post-TB disability, we can target rehab services, and in those 7 countries, I believe, with current post-TB guidelines, we can refine those for better outcomes. So EPI in action, epidemiology basically allows us to generate evidence and transform high-quality research into action. We know that policymakers rely on robust data to justify changes in guidelines and algorithms, efficiently introduce and effectively allocate resources, as well as implement new care models. And evidence from epidemiological studies on post-TB respiratory impairment can support the inclusion of spirometry, for example, and advocate for rehab services in post-TB programs. And we see this in action in lower resource, higher burden countries like Brazil, where the Thoracic Association has now recommended the management of post-TB lung disease, as well as in relatively lower burden, higher resource countries like Canada. And just to bring it back to the continent, Kenya has also developed some post-TB guidelines recently, all of which we can draw from. And to close out this part, although we will speak a lot about numbers and methods, epidemiology is more than that. It's about people and improving lives. And as the public health fraternity in this room and in other rooms like this, we should consciously collect data, appropriately analyze through collaboration and critique, responsibly interpret, and accordingly act on data to bridge the post-TB gap. Thank you.
Perfect. Thank you so much. Next up, we have Dr. Alva O'Reilly, who's a clinical research fellow and an MD research student. She previously gained a distinction in the epidemiology master's at the London School of Hygiene, and her MD research project will use mixed methods approach to determine whether TB survivors in the UK have unmet health needs.
Great. Thanks, Camilla, and thanks for having me. So the title of this section is, what is the epidemiological question? And our aim here is to describe broadly the 3 main types of epi questions, what their goals are, and what methods we can use to achieve these goals, and what pitfalls we need to be aware of. I'm very much aware that there are probably some eminent epidemiologists in the room, and so if you are one of those people, please just relax and see this as a bit of a refresher of the key concepts. So, firstly, descriptive type of questions. These are asking what is happening, to whom is it happening, how often, where, and when. Predictive type of questions are asking, how can we best predict this outcome? And causal questions are asking, does this specific exposure cause this specific outcome? And I thought that we might illustrate these kind of questions using my own project as a case study. So the background here is that over 165,000 people have been diagnosed with TB in the UK since the year 2000. That's one thing we do know for sure, but we don't know what their post-TB health outcomes are at the population level. National TB surveillance data, which is fairly good quality, does exist in the UK, and it can be linked to mortality data and primary and secondary care data. We've done a short preliminary analysis which does indeed show that there is lower life expectancy among TB survivors in the UK. My project's overall question is, what is the health of UK TB survivors? And one key outcome that we're looking at here is mortality. So using this example of mortality, the descriptive question here is post-TB mortality, what is happening? And there are many different ways that we can describe this. We can estimate a mortality rate. This is simply an incidence rate of death among TB survivors. We can use Kaplan-Meier curves to illustrate how how survival probability overall is changing during the period since they either were diagnosed with TB or completed TB treatment. Within this, we might also be asking, when is death happening? To answer this, we can estimate a median age, a mean age. We can estimate the proportion of people who are passing away early on after they completed TB treatment versus later on after TB treatment. We can look at temporal trends, so we can compare rates in one decade to another decade. We also might want to know, to whom is this outcome happening most often? To answer this, in this case, we can estimate stratified mortality rates. So here we're trying to answer how often is death happening within certain groups of TB survivors. And we could group them based on socioeconomic status, ethnicity, and various TB-related factors as well. And to illustrate this, we can draw Kaplan-Meiers with separate curves for each type of group. And here is a nice study from Emory, which shows stratification of the Kaplan-Meier curves by foreign-born versus US-born status and HIV status as well, which is quite a nice descriptive analysis. We can also ask, where is mortality happening? So we could stratify by regions if we wanted to. There are various challenges to the descriptive analyses. One is in relation to definitions. And I think you might want to define TB survivors as those who have completed treatment. And then there's a question about what to do with people who are being diagnosed with recurrent TB, and obviously this is something which we've talked a lot about. And how well defined is your outcome? I've chosen death because that's got quite a clear definition, but as we've learned, we haven't quite reached consensus on a lot of post-TB outcomes. So that's something that's really important to think about. Another challenge is measurement bias. Is your data being accurately recorded? In my example, many deaths might not be captured reliably in my data set. Lots of TB survivors leave the UK, and so this might lead to an underestimate of the mortality rates if we're not capturing those deaths. Another challenge is selection bias. So do the participants selected for your study actually represent the population that you're trying to describe? Who might your data sets be excluding? So in my case, I need to think about whether homeless TB survivors or unregistered migrants are appearing in my data set. And often these vulnerable groups who are excluded might have higher mortality. And again, this might lead to an underestimate of their mortality rate overall. And doing descriptive analyses often leads to further questions, which is a good thing. So, for example, if we find that certain groups do indeed have higher mortality rates, we then might want to try and predict their risks of mortality, potentially on the individual level. If we notice that rates seem high compared to rates among the general population, that might then mean that we start asking, but is the TB actually causing an earlier death? And this is something which, when I present about post-TB, other clinicians are often asked, is it really the TB that's causing the earlier death here? And often you might feel that your descriptive analysis simply isn't enough to convince people such as policymakers. You might think, if I were to compare TB survivors to TB-naive people in the general population, this would give me a rate or a risk ratio, and this is a more convincing kind of single output to have. The next type of question is predictive, and in this case study, we might be asking, how best can we predict mortality, the outcome here, among TB survivors? And the answer is predictive models. So these use a combination of variables to estimate the probability that this outcome will occur for the individual in front of you in the future. One example of this is the Isaric model, which was used widely in COVID-19 to predict deterioration, for example. So in our case study, we might be asking, what is this TB survivor's mortality risk based on knowing certain factors? so that people identified as being at high risk can be directed to a specific care pathway, monitored and given preventive treatment. One key question to ask when we're looking at predictive models is how accurate is the prediction? And the key metric here is the AUC, the area under the curve. And this tells us how much better is this model compared to just giving the person a random classification. And a value of 0.5 means it's no better than a random classifier, and a value of 1 means it's absolutely perfect. And there are various challenges. I think I missed a slide. No. Various challenges to using predictive models. One is measurement bias, similar to as in descriptive analyses, this remains a problem, alongside selection biases. And if we have biased data going into a predictive model, we're going to get out biased and inaccurate predictions. Other challenges include having too simple a model. If we've got too few parameters in the model, we're going to get inaccurate predictions and it will be prone to bias. If a model has too many variables in it, it may fit our training data very, very well, but it may be less accurate in the real world with a broader data set. In predictive models, we need to be clear that validation has been robust. So we should always ask, has this model been evaluated in the intended target population for implementation? And more importantly, has it been evaluated in your specific context? And there are various methods for doing this, which I won't go into. The final question is the causal question. So in this case, does the previous TB, the exposure here, directly cause mortality, the outcome? So one analysis to answer this question would be a multivariable regression in which we compare the mortality rate among TB survivors to the mortality rate among TB-naive people. And to do so, we also want to adjust for confounders. Sorry, slides have got a bit out of order. But what is a confounder? So a confounder is something which is both associated with the exposure and also a risk factor for the outcome. And so the apparent relationship that we are finding between the exposure and the outcome can be explained by the confounder. So it's distorting the relationship that we're seeing. And this is something to be very much aware of. So one thing which we may, so it's very important to be aware of the fact that confounders can exist and they might not have been measured accurately. Every time that we find an association between an exposure and an outcome through a multivariable regression analysis, it's important to be aware that this is only an association. You may have had a causal question going into that analysis, but your output is an association. To make the next step to saying that this is a causal relationship requires more complex analysis, and it requires a lot more in-depth thinking. And this is something which Camilla's going to talk about in a little bit more detail afterwards. And you may want to construct things like conceptual frameworks or directed acyclic graphs in order to be clear on whether or not a causal relationship exists. But if you do think it is very plausible that this is a causal relationship, one thing you can then do is a mediation analysis. And here you'll be asking which mediators explain the effects of previous TB, your exposure, on death, the outcome. So what's a mediator? A mediator is a variable which explains how the exposure is having an effect on the outcome. It needs to lie on the causal pathway, and it must not be a confounder. So one example might be if TB is the exposure and cardiovascular death is the outcome, and we have some way of measuring new types of atherosclerosis that occur, then atherosclerosis would be the mediator of this causal pathway. Another type of causal question might be, does this intervention cause a reduction in this outcome? So, for example, it might be a randomized controlled trial comparing respiratory symptoms, which is the outcome here, among TB survivors who are receiving pulmonary rehab versus those who are not receiving it. So that's your unexposed control group. Important to take note, all of the issues relating to confounding aren't a problem here because randomization should have taken care of it. And from this, you can have a risk ratio, which will tell you the association between pulmonary rehab and a reduction in symptoms. So there are various challenges to causal studies. Again, measurement and selection biases play a role, and they could overall underestimate your effect size in terms of your ratio. It's important to think about confounding and whether or not you've included all potential confounders in the model. I think in the area of post-TB, it's very difficult to say that there is no unmeasured confounding at the end of your study. So that's a particular challenge in this area. And establishing causality is a complex task and requires strong study design and appropriate analysis. So hopefully we've convinced you that it's important to think about what your epidemiological question is so that you can align your methods to that question in order to achieve your goals. One other thing to think about is other types of data. So obviously I've talked about quantitative data, but might other types such as qualitative data help to contextualize your quantitative epi findings? And in my study, we thought it was important to include focus groups and interviews with TB survivors in order to contextualize our quantitative findings. In summary, it's important to be clear on what your question is, make sure your methods align with it, and be aware that there are pitfalls. Thank you.
Thank you, Alva. Okay, I'm going to talk real fast through this. So we're going to shift gears a little bit, and in this section, we're going to explore how we can apply epidemiology to tackle some of the big post-TB questions. Questions that are complex, multi-layered, but they're central to improving outcomes. So the two questions I would like to focus on. First, how do we capture and characterize the diversity of post-TB outcomes? And second, how do we isolate the causal effect of TB on long-term outcomes? Again, big picture questions that each require thoughtful, data-driven approaches. So how can we capture and characterize the diversity of post-TB outcomes? This is a fundamental issue. Two people can complete TB treatment, but have very different experiences after treatment. One person may fully recover, while the other person may face significant and lasting physical, psychological, or economic hardships. And this variability is really important. If we want post-TB care to be person-centered and evidence-based, we need to understand and describe the diversity and complexity of these outcomes. So for this presentation, I'm going to focus on post-TB lung disease as an example. But again, the approaches I discuss can be used for a wide array of post-TB sequelae. So what do we know about post-TB lung disease? I think I will be the 19th person to mention the systematic review that found that approximately 60% of people who complete treatment for pulmonary TB experience abnormal spirometry. And this is significant, but there is a catch. This is just an overall summary estimate. And while overall estimates are incredibly helpful for summarizing data and showing us the big picture, they can also be a little bit misleading, especially for a population as diverse as TB survivors. Why is this? Well, first, we know that post-TB lung disease is complex. It can affect different parts of the lungs, as shown on the figure in the slide, and symptoms can widely vary between individuals. Number two, it appears that the respiratory impairments that we see are dynamic and they evolve over time. So what we see from the slide here is work led by Dr. Sarah Ald and Dr. Gregory Bassan, which shows that the spirometry patterns that we see immediately after treatment aren't necessarily what we'll see 6 months or a year later. So this means that when we present a single time point, we can be obscuring important nuanced details. And this has been really thoughtfully illustrated by exploratory work led by Dr. Sophie Huddard, Becky Nightingale, and Jamila Maheji, where they've used longitudinal repeat measure spirometry data from the Malawi cohort, so a cohort of individuals in Malawi treated for pulmonary TB, and a method called group-based trajectory modeling. Again, this is just an exploratory analysis. It's not finalized, take it with a grain of salt. But I believe it's incredibly interesting and worth showing. So what you can see on the figure of the left is the overall median FVC from the cohort, which appears to increase and then kind of essentially plateau. But when we look on the right, we see from the results of the group-based trajectory modeling that the median experience, the average trend is not necessarily representative of the average experience. So from the boxes that we see there, approximately 56% of people shown in boxes D and E had stable spirometry patterns. 35% were in the increasing FVC trajectory group, so boxes B and C, and about 9% had a declining FVC pattern. So the key thing to remember here, again, exploratory analysis, is that relying on these overall summary estimates can hide important subgroups, or to use language used in the phenotype group, distinct subphenotypes, who may need different kinds of care or follow-up or targeted interventions. Now, these trajectories are only the first part of the puzzle. Once we've identified them, we can start asking, are there early features, clinical, demographic, biological, social, that are associated with each pathway? Are there modifiable factors on these pathways we can intervene on? Can we develop risk predictive models for the pathways associated with poor outcomes? And this kind of thinking allows us to shift from a reactive model of post-TB care to a proactive one, where we're not just responding to disability after it occurs, but we're identifying and supporting people before their condition worsens. Now, what if we don't have repeat measure longitudinal data to run these analyses, which, let's be honest, is a problem for many researchers? Well, we've got other tools in our toolbox that can help us uncover patterns. So one of those is a latent class analysis, which is a technique used to uncover latent or unobserved subgroups. It's particularly useful when we suspect there might be differences, like we've talked about in post-TB lung disease, but we don't actually know yet how to define them. Similarly, we can use k-means clustering, which is a machine learning approach to identify clusters. And if we're not using modeling techniques, we can still explore pre-specified stratified analyses. So here we ask ourselves, do these outcomes vary by age? And if you come to the pediatric session later today, we will not only convince you you should be including pediatric populations in your research, but you should also be stratifying your outcomes by age groups. Also, you can ask yourselves, do your outcomes vary by sex, by HIV status, by TB type, or by baseline lung function? And again, these are all estimates that would be completely masked if we were just presenting overall summary estimates. Uh-oh, hold on, sorry, give me 1 second. There we go. So coming back to that first question, how do we capture and characterize the diversity of post-TB outcomes? Well, to do this, we need to consider analyses that reflect the complexity and diversity of the post-TB experience. And this is beautifully highlighted in the pathogenesis presentation, where we need to anticipate and embrace this complexity and reflect it in our analyses. Okay, barely scratched the surface on that one, but we're moving on to question number 2. So how can we isolate the causal effect of TB on long-term outcomes? So essentially here, what we want to know is what we're seeing post-TB due to TB, or is it due to a pre-existing condition? Now, again, a central question, one that is asked very often and one that is incredibly difficult to answer. So again, let's take post-TB lung disease as an example. When someone has breathlessness, chronic cough, or fatigue after treatment, what's behind it? Is it lung damage from TB? Is it a pre-existing condition like asthma or COPD? Or exposures like smoking or pollution? Or is it something like malnutrition? And this has been incredibly laid out in this conceptual framework of drivers of post-TB lung disease recently published. And Just to kind of illustrate this, when we look at work led by Dr. Marika van der Zam with her and her team, they found that 58% of healthy adolescents from the same socioeconomic background as those with TB had lower than expected lung functions. So we see that this causal question is an important one to ask. The impairment we see post-TB, how much is due to TB and how much is due to pre-existing vulnerabilities? Now, as Dr. O'Reilly highlighted earlier, this is fundamentally a causal question. And to answer this, we need to think like epidemiologists. And the first thing that we want to do is think about the counterfactual, the what if. What would this person's health have looked like if they didn't have TB? Now, of course, we can't observe both outcomes for the same individual, so instead we'll use data and thoughtful study design to approximate this comparison. Now, the next thing you want to think about is what might be influencing our exposure and our outcome. And the way we can kind of think about drawing this relationship is with directed acyclic graphs, or DAGs. This one was done by Dr. Andrew Basham, investigating the relationship between TB and airway disease. Building a DAG is complex, it is iterative, it is collaborative, but that's the point. It forces us to slow down, to clarify our assumptions, and to build a shared understanding across disciplines. TB DAGs are complex because TB is complex. Okay, we've got our counterfactual, we've built our DAG, what do we do next? Well, as Dr. Matt McGee pointed out, we can't randomize people to develop or not develop TB and then follow them for years to see if they develop sequelae. So we have to do this using smart study design and observational data. Here, birth cohorts are particularly useful because they let us follow individuals over time, starting before they develop TB, and they help us establish temporal ordering and rule out reverse causality. A beautiful example of this work is led by Professor Heather Czar with Dr. Leo Martinez. And this team can follow children from birth so they can examine how TB interacts with other life course exposures and determine whether observed outcomes are due to TB or reflect vulnerabilities already in place. We also have powerful analytic tools to tackle causal questions. A few years ago, we wanted to take a causal lens to see if TB leads to increased healthcare use. And so to answer this, we used two methods, propensity score matching and an interrupted time series analysis. I'm not going to go into tons of detail because I am running out of time, but essentially what we found is what most likely exists is a dual reality. People who develop TB, sorry, I've lost my thoughts. Many people already face challenges before TB, but TB itself also seems to worsen those conditions. Now, causal inference is a science of its own that needs more than 6 minutes to discuss. So for individuals who are interested in causal approaches, there's many free resources out there, including this incredible book called What If? There's also a course from Harvard, also free, that lets you think through your assumptions and drawing DAGs. Highly recommend both of those. What can we do now, though, if we're not actually designing causal studies? We can begin by laying the groundwork, collecting and curating data that allows us to ask causal questions. So things like pre-existing conditions, social determinants of health, access to care, TB disease severity and treatment. Think about asking yourself, what are the key variables that could confound or modify the relationship I'm interested in? What information can I start collecting now, even if it's imperfect, that will strengthen the questions I will ask later? And so returning to this question that I have absolutely no answer for, how can we isolate the causal effects of TB on long-term outcomes? It's not a simple task. It requires the right tools. It requires careful thinking about the web of factors that shape people's lives, and crucially, the right data. We need to remember that TB doesn't occur in isolation. People carry with them the biological, social, and structural vulnerabilities that influence both their risk of TB and their outcomes after treatment. To truly understand the impact of TB, we need to account for these underlying factors. And this is where collaboration is key. Causal questions aren't solved in silos. We need to combine insights from clinicians, epidemiologists, statisticians, and people with lived experience to really ensure that our analyses reflect the real-world complexity and meaning. So I'm going to wrap up here. 3 take-home messages. First one, epidemiology is more than numbers. It's about asking the right questions. When used thoughtfully, it reveals patterns that challenge our assumptions and guides better decisions. Number 2, post-TB is not one condition. And to support person-centered care, we need the tools that help us make sense of this heterogeneity. And then number 3, analytic methods drive action. Whether it's program design, policy, or advocacy, strong epidemiology helps ensure our work is effective, equitable, and evidence-based. Thank you.